Hello. Um, Wanted to get this recorded. It's like midnight, and I've got clinicals in the morning, so we will hopefully get this done in our first shot. So, haha, I did it on the first try. All right, so this is just kind of an overview part of it. Kind of goes back to A and P. Voluntary muscles have nerve impulses. That's how they contract. They also need blood supply to it, and they need oxygen. Obviously, it's provided by the circulatory and the respiratory systems. Long bones, the ends protect the red bone marrow, and the muscular system, their function is to move or stabilize the skeleton so that it makes the body be able to move, and it holds the bones in the places that they're supposed to be. Bones store calcium, and this calcium reabsorption is what that is supposed to say. The calcium is reabsorbed from the bones so that the calcium in the blood stays at a hopefully normal level. Obviously, calcium is for blood clotting, nerve functioning, muscle functioning. If calcium is actually low, I think we went over this. I don't remember which part it's in, but it causes muscle cramping, sore muscles, muscle twitching. So it really needs to be at an appropriate level. But like we talked about in class, it takes it to be very, very abnormal before any symptoms start to show. Here are some of the vocabulary that I told you guys to go over. Osteocytes are just bone cells, and that's kind of like the umbrella term. Osteoblasts are the cells that repair bone. B for, I forgot how did I have this? Oh, B is for build. So if you remember, osteoblasts build bone, and osteoclast removes the bone. So if you remember, osteoclast, the C is condemn, so that way you can kind of keep them straight. You guys can look at the notes here. I don't want to read off the notes. Obviously, the longest bone in the body is the femur. I'm just kind of trying to give a quick overview of this. Aging. Bones tend to become much more brittle and easier to break once a person ages. So when their estrogen and their testosterone levels fall, that's when you'll see the osteoporosis or the poor or the soft bones. Muscle mass and strength is also going to decrease as people age. Ligaments, tendons, and cartilage are also less elastic. Intervertebral spaces actually decrease. That's when you hear people say, I've lost height, because everything's kind of drying out. Changes in posture, obviously, a big thing is the decrease in intervertebral space. And any of the changes in the musculoskeletal system lead to impaired mobility, bigger, higher risk of falls, and obviously pain. Looking at the notes here, safety, I know I just talked about the risk of falls. Elderly people who live at home really need to have look at their setup of their house. So if they have throw rugs, get rid of them. Cords in places that they walk, get rid of those. Stairs, if you encourage them to get like a bright colored duct tape and put on each step so that they can see where the stairs are, because sometimes their depth perception is poor. Really encourage them to sit on the edge of the bed and dangle for a little bit. because if they stand up too fast, obviously they're going to get have orthostatic hypotension. Yeah. You guys can look over this. Calcium level 8.5 to 10.2. Oh, this is where I was talking earlier. The levels need to be really low or really high for any of the symptoms to start showing. So if it's really high, you're going to see people with fatigue, they're going to be weak, decreased appetite, nausea, vomiting, but they're still going to be thirsty, and then also constipation. Low calcium is much worse than a high calcium because you're going to see, like I said, the abdominal cramps, the muscle cramps, the tingly fingers, the muscle twitching when it comes to low calcium. Oops, sorry. Ari, hush. Sorry. So tests. I know we kind of went over this, and I do have some on my notes, but I really want you guys to know the CK, the creatinine kinase level. The CKMM is specific to skeletal muscle. So anytime that the creatinine kinase is elevated, it means that there is some type of muscle disease, muscle destruction, a wasting of the muscle. This is seen especially in something like rhabdomyolysis. We talked about it in class. These are the little old ladies who fall, or little old ladies, little old men who fall at home and aren't found for, a couple hours to, I've seen people not be found for 24 hours that ended up with rhabdo. What happens is that skeletal muscle is destroyed, trauma, the muscle tissue actually breaks down, and then when the muscles break down, the byproducts are released into the bloodstream. And once they start circulating in the bloodstream, obviously they got to go through the kidneys to be filtered, and especially the myoglobin can actually kind of clog up the kidneys and cause kidney failure. Normal CK is 94 to 100, and this will just tell like inflammation or destruction, disease or damage of the muscle if this is elevated. Alkaline phosphatase, generally we see the ALP as a liver lab, but it also will tell you about bone damage. And myoglobin, if that's present, obviously that has to do with the rhabdo, like I just said. When somebody has the wasting or the damage to the skeletal muscles, you'll see that. Other diagnostic test is the erythrocyte sedimentation rate. This is the ESR. Generally, it is very vague. If it's elevated, it just tells us there's inflammation somewhere in the body. It's just measuring the rate at which the red blood cells settle out of the blood. C-reactive protein, the CRP, you probably heard it called, normal 0 to 5, also tells us that there's inflammation somewhere in the body. It's not specific, but it increases quicker than the ESR. So generally they'll both be done, but the CRP will show damage quicker than the ESR. Rheumatoid factor, the RF. Generally, if somebody does not have like rheumatoid arthritis, this will be negative. If it's positive, generally they are looking for rheumatoid arthritis. The body actually makes the antibodies against the body. So when they're looking at this, this is just looking for those antibodies. If they're present, then this person does have like a rheumatoid arthritis. Like I said, I keep repeating myself. I'm kind of tired, but the ANA, the anti-nuclear antibody, is generally done looking for like lupus. It's systemic lupus erythematosus. It kind of tells us about autoimmune disorders. And then Pam did add the uric acid levels in the notes. Generally, when we're looking at uric acid levels, we're looking for gout. Males is generally 3.5 to 8. Females is 2.8 to 6.8. Generally, this is when people can't, has to do with the purines in the diet, and generally this is like the smoked salamis and the cheeses and the beer, so we do kind of say it's an elderly male illness. You guys can look through the myelogram, the MRIs, the arthrocentesis, and the gallium-thallium scan. Arthroscopy. You guys have heard of people when they say they're going to have a scope. It's just that they're going in, looking at the inside of the joint, done under anesthesia. All right. Let me get my... So I know I kind of went through that kind of fast, but you guys can review that. It's kind of more of a A&P review type thing. So, Pam's notes here. The 5 P's of musculoskeletal. Pain, pallor, paralysis, paresthesia, and pulse. You can remember it that way with the 5 P's. You can also do what's called a CMS check. Circulation, movement, sensation. When we do either one of these, we're looking to see if they're like if they've had a knee surgery. We're going to look and check and make sure that their foot and their toes are pink. We're going to make sure, can you wiggle your toes? We're going to do capillary refill. We might even do that on the skin. And then we're going to ask, do you have any numbness or tingling? Anytime that there are changes, this needs to be reported to the provider right away. A good example is compartment syndrome. That's kind of it on that page. Carpal tunnel syndrome. The median nerve is just compressed in the wrist when somebody does repetitive movements, and it happens, it takes quite a while to get it done. Generally, these people are going to have finger, hand, arm pain and numbness, especially at night. So a lot of people do wear braces to bed, and that seems to help. They will wear the splints, the braces during the day too, but generally a lot of people wear them at night, and that seems to help. It just kind of opens it up while they're sleeping. They're going to be put on an anti-inflammatory, maybe like prednisone, and then also there's that wonderful surgery, the carpal tunnel release. And then teaching prevention, kind of wiggle your hand around, try not to do repetitive motions over and over. Fractures, we all know what these are. It's just a break in the bone. Can be caused by trauma, or it also can be caused by disease. We'll get into more of osteoporosis, but an example of that is when the little old lady who has osteoporosis turns the wrong way, she might break her hip and then fall, but the fracture is not from the fall, it's from the osteoporosis making her bones weak and brittle. Open fracture just means that the bone breaks and comes through the skin, and a closed fracture, the bone breaks but does not come through the skin. Open fractures obviously are a huge risk for infection because those bones are right there, they break through the skin, you might get infection in the skin, and since the bone is exposed, I know I stressed this with you guys during class, but whenever the bone is exposed, it is at a big, huge risk for osteomyelitis to get infection in the bone, and that's very hard to cure and very painful. So signs and symptoms, it just kind of, it really depends on which bone is broken. There's going to be pain, like terrible, terrible pain. The patients aren't going to be able to move them. And like a hip, when somebody fractures their hip, one of the big assessments to do, you find them, they fell and you find them. Look at their legs. If their leg that is broken is tilted inward or outward, it's a good sign that, maybe that hip is broken. A deformity, I've seen hips that, have a huge, instead of being straight down and symmetrical with, on each side, you can basically see the broken bone. Again, with hip fracture, you're going to see that one leg, the broken leg, will actually be shorter. So just kind of remember that when you're looking at people who fall. Obviously, there's going to be swelling and there's going to be bruising. And we all know that broken bones are diagnosed with an x-ray. Emergency treatment. If they have a fracture, you want to make sure that they don't have any other injuries. Respiratory distress or bleeding, head or spine injuries, they all take priority to the fracture. A fracture will not kill anyone, but respiratory distress, bleeding, head injuries, spine injuries, they will kill someone. So always make sure that you are triaging and making sure that, if there are other injuries that are more serious, that are more life-threatening, are taken care of first. Sprint it as it lies. Do not try to move it. If you are, maybe you come across a car accident, or you're working in the nursing home and somebody falls, splint that bone as it is. Do not try and rotate it. Do not try and line it back up. Just splint it the way it is. Do CMS checks to say if they've got a broken arm. Do the CMS checks on their hands so that you're making sure that they don't have any possible signs or symptoms of, decreased blood flow to that extremity. And again, do not straighten or realign it by yourself. And that is something that is done in under sedation by a doctor. Fracture management. If it is displaced, we want to make sure that that bone gets realigned. Like I said, that's a doctor thing. Do not try to do that as a nurse. And we want to make sure that it's immobilized so that it can heal. Close reduction is just basically the provider is grabbing both sides of the break and putting it back in place. There's no incision, there's nothing like that, but it's just basically grabbing, so if you maybe fractured your tibia, they're going to manipulate it, holding on to both parts of the leg, the upper and the bottom part of the lower leg, and put it back into place. Sedation and pain meds are going to be used because it is very, very, very painful. And they may have a cast. Just depends on where the break is, why they're needing it. And they also, for closed reduction, you will see traction. And we kind of talked about that in class, where if somebody has a displaced fracture, it's painful because the bone ends are rubbing. It's damaged bone ends. So if you imagine you have a cut, say on two fingers, and you rub them together, that's painful. So imagine with the bones. But once the traction is placed, it'll pull each side of the bone together, put it back to where it's supposed to be, and it actually decreases pain a lot. But we'll get into traction a little bit later in the slides. Alright, casts. Never grab onto a wet cast or put it on a hard surface. We really don't want to have any indents, any deformities in that cast because we can see it on the outside, but we can't really see what it's doing on the inside. And if that cast is, we've got our fingertips pushed into it, that'll be pushing on the body. Let's say if they broke their ankle, they have a boot cast on, and we hold their calf. Those little indents will push on the calf and can cause compartment syndrome, that can cause ulcers, and then we wouldn't know about it until it was too late. Make sure the edges are smooth so that they're not cutting themselves, because the plaster and cast can be very, very sharp. Always make sure that we are elevating that extremity wherever that break is for at least, I say, 2 days, just to get that swelling down. We also talked about this in class too, where somebody breaks a bone. They might have a soft cast that allows that swelling, and then come back in 3 days or so to get the hard cast on, just so that they can account for that swelling. Because if you put a hard cast on and it swells, you're going to have problems with compartment syndrome. Always ice. The breaks, the ice will go through, the coldness will go through the cast. So what do we assess? Make sure that cast is dry, make sure their skin is dry, so that they're not moist and itchy underneath that cast, because that can lead to a lot more problems as well. We want to make sure that the cast is not too tight. Make sure that there's not any drainage coming from the body part, any odor. Odor can mean a lot of bad things. We always want to make sure that we're doing CMS checks to the distal part of the extremity, and then we're going to assess the skin around the cast just to make sure that they're not breaking down. We call it palming the cast, but that just means you're handling it with your palm, so you're not sticking your fingers in the cast and leaving indents. Alright. Just some different pictures. Spica cast, long arm cast, short arm cast, single spica, 1.5 spica, bilateral leg cast, short leg cast, long leg cast. Yeah, it's just all sorts of different ones. Alright, so here's our traction. I kind of like this picture, it's cute. So if you have a bone, say the femur, I've used traction quite a bit with femurs, but this big bone is broken right down in the middle, and the bones are displaced, rubbing against each other. That's going to be very painful. So you're going to put, it's kind of like a, I don't know, like a little coat for whatever, the part of the extremity, and it's linked to these weights. The weights are then over the edge of the bed, and kind of pull that bone back into place. This will help pain, this will help with muscle spasms, because when a bone is broken and it's moving around, the muscles are going to get really mad. With these people, we need to make sure that every single time we go in their room to talk to them, to get them water, to do their vitals, anytime we are in that room, we need to stand at the end of the bed and look up at them and make sure that they are in straight alignment. Everything needs to be just lined up perfectly. People get bored in bed and start moving around, can actually cause that fracture to displace again. If people are complaining of increased pain before handing them a pain pill, we need to just check this first. I mean, obviously medicate their pain if they need it, but this needs to be one of our assessments that are done when our people complain of pain. Also with traction, we need to make sure that we're watching for pulses, just because it can be maybe the securing like a little coat, little wrap, is too tight, or maybe that bone has become displaced and is actually blocking blood flow. So we need to always, always, always assess for pulses in distal extremities. Also on here, if kids are in traction, this can be very difficult. Hold on, I gotta talk to my daughter and tell her to be quiet. Alright, sorry about that. Kiddos, we need to make sure that they have a lot of activities so that they are not trying to move around, getting bored in bed. The only time you'll hear me say, let them play on the phone and keep them still, because they can only watch so many movies or whatever they need to do to stay still and keep that fracture in alignment. An ORIF is the open reduction internal fixation. So they're going to go to surgery. The surgeon is going to actually cut open. They're going to realign those bones and actually look at them. And then plates and screws are going to be placed. So all the plates, all the screws, any of the hardware will be, inside of this incision. As you can see on this x-ray here, you've got screws, you've got a plate, and then on the outside of the hip there's a whole lot of staples. So this just means that they're fixing the bone. The plates and screws are inside, so they're opening it up, they're reducing the fracture and putting it realignment, and the internal fixation is the plates and screws. Sometimes the hardware is removed, sometimes it's left in place. Just kind of depends on the person, where the break is, what type of hardware was used. Alright. External fixation. This looks like a barbaric torture chamber to me. So when a bone is broken, maybe like a crush injury, maybe there's multiple fractures, or maybe there's lots of little, like it's shattered, that's when they will use this. So they have like a wire cage on the outside of their bone, and these pins are inserted into the bone to hold them in place once that bone is put back into place. With the external frame, it's really keeps all the pins, keeps the bones, keeps everything where it needs to be. I have actually seen this quite a few times. One, I had a kid who was playing soccer, and another soccer player kicked his tib fib instead of the ball, and he ended up getting compartment syndrome and had a wound vac on top of this apparatus. So, I also had another young lady who had shattered her ankle and was in external fixation for quite a long time. And you actually, when you do the dressing changes and cleaning of the wounds, you need to clean around each one of these pins and dress it with a dry dressing. And you just work around all the apparatus. So when we are doing the care of it, obviously always watch for infection. Not only skin infection, but these pins are straight into the bone, and those bugs can climb down the pin and go into that bone. So we're going to always look for redness, swelling, drainage, increased pain, a fever. A big sign or characteristic sign of osteomyelitis is that sudden fever, and then chills. They really get chills because it's kind of almost a systemic thing. All right. So what are some complications? There's a bunch of different things. There's hemorrhage because of the red blood cells are stored in the bones. Obviously, infection is a big risk. Can be a skin infection, maybe from an open fracture. Maybe it was a dirty environment where they broke their leg and the bugs crawled and gave them a skin infection. Can be an infection in the bone if it's an open fracture, or maybe they have the external fixation, or even if they broke their ankle, had surgery, they can get an infection in the surgical incision, or even if it was a closed reduction. If they have a cast on, maybe their leg gets wet and causes like a yeasty infection. So the possibilities of an infection with a fracture are endless. Obviously, thromboembolic complications, they're not as mobile as they usually are, so they are at high risk for DVT or even a pulmonary embolism. Acute compartment syndrome, which we will get into in the next one, fat embolism syndrome, which we'll get into, and then non-union. Just because the bones get put back together where they're supposed to be, sometimes there are some complications where these bones do not form and do not heal back together. So make sure you know all of these complications, their symptoms, and what to watch for. Because if you have somebody with a fracture and you miss some of these things, it can end up a whole lot worse than if you would have understood what was going on and caught it. When we get into compartment syndrome, I'll tell you my story about I can't believe if they were a knee, a total knee. So just make sure you know what each of these are and what you need to do in case you come across it when you're practicing. Acute compartment syndrome. Yeah, this is really what it looks like. So what it is say somebody has a broken bone and the cast is put on. So you have this increased pressure from the inside, but you don't have anywhere for it to go because you have that tight cast on it, confining it. So it's really just, it's swelling, but the swelling has nowhere to go. So it will damage damage the tissues because that blood flow cannot get moving around there because of the swelling, the fluid or whatever. That blood flow is not appropriate. So it, the tissue, that compartment that's swelling, that has nowhere to go, can actually become necrotic and die. So the first treatment, we're going to remove the cast, we're going to remove the ACE wrap, whatever it might be. And then they might actually need what's called a fasciotomy, where they go in and they surgically open up that muscle, and open the covering to the muscle, the fascia. Compartment syndrome can happen quickly. My story, I had a lady who had just had her knee done, and obviously the dressings are put on back in the OR, but once they start moving around because they're marching the night of surgery, actually now they're going home within 24 hours, but they're moving around, and the ACE wraps and all the cotton and the dressings underneath can get, even tighter. So I had a patient, she was complaining of pain. I medicated her, and her pain just kept getting worse no matter what I medicated her with. And first dressing change is always done by a doc. So I was really kind of, nervous to open that dressing up. But I did. I actually kind of pulled at the ACE wrap, pulled out some of that cotton batting, and kind of loosened it up as much as I could. And honestly, that worked so much better than any of the pain meds that I gave her. And I did, obviously notify the doc right away, so that when he came in the morning, he was able to watch for it. Compartment syndrome is a medical emergency. The doctor needs to be notified immediately, whether it's a doctor, whether it's a surgeon, because they can actually have necrosis and lose that limb. So the doctor needs to be notified immediately. This one is actually a fasciotomy. You can see where the fascia was cut, and they've left places for swelling. I had a kid, like my soccer player, he had the tib-fib fracture and the external fixation, but then he also had these little kind of football shapes because he had gotten compartment syndrome, and that was the only way to reduce the swell, or to give a place for the swelling to go and get that blood flow back to where it needs to be. kind of went over this. Pathophysiology of a compartment syndrome, it's just that pressure in like I guess you call it a compartment. There is decreased circulation, but that pressure, that swelling, basically has nowhere to go because there's, something constricting it. Causes the cast, the ACE wrap, whatever it is that is just not allowing that extremity to swell. Like I said, a big sign and symptom of compartment syndrome is that pain that no matter how many opioids you give them, it's not going to help with the pain at all. They're going to have decreased sensation in that extremity. And here it says the 6 P's: pain, paresthesia, paralysis, pallor, pulselessness. Those are the 5 that I'm more worried about. Poikilothermia is basically they're not able to regulate their body temp. So remember the 5 P's. Treatment, we went over this. They can bivalve a cast, or they can do a fasciotomy. And where they do a fasciotomy, those wounds, like I said, they'll leave it open, those football shapes, until that pressure is decreased and the blood flow is returned. All right, next one, fat embolism. This is especially in the long bones, especially like the femur, or maybe there's multiple fractures, and it can happen up to 72 hours after the break. So it's these little globules of fat are released from the yellow bone marrow in the bone when it breaks into the bloodstream. Once it hits the bloodstream, it's going to travel around the body, and of course it's going to travel right to the lungs because that's where it's going to cause the most problems. So their symptom will be respiratory distress. Their oxygen saturation will drop, so they're going to have a change in their mental status. They're going to be confused. They're going to be out of it. Their pulse is going to go up. Their respirations are going to go up. Their blood pressure is going to go up. But the characteristic sign of a fat embolism is this petechiae on the chest, on the like in the axillary area, upper arm area. So just know that you'll see respiratory distress with this petechiae. So what do we do about it? We're going to give them oxygen because they're going to obviously be low because there's going to be a blood clot blocking any of the oxygen exchange. We're going to get their head of the bed up because it's easier for them to breathe. We're going to notify the provider, and if there is like a code team or rapid response team in your facility, we're going to activate them. We're going to keep these people in bed. We're not going to get them up. We're going to call for an x-ray to come to bedside, and then ABGs. That way we can know what's really going on. Alright. Osteomyelitis. This is just infection of the bone. Bacteria enters in some way, maybe an open break or the external fixation, pressure ulcers, any time where that bone is exposed. So the infection starts, and then because of that infection and that inflammation, there's going to be less blood flow to that part of the bone, and so the bone is actually going to die off. It's going to become necrotic. So it's very painful. It's hard to treat, and it usually takes quite a long time if people can recover from it. So we need to prevent it. We need to make sure we're being clean when we're changing dressings. We're going to make sure that when we're doing cares with foot ulcers, we're keeping everything aseptic technique. One big thing that a lot of people miss because eschar is usually removed, if a patient has dry, stable eschar on the heel, we do not want to remove that. If that is debrided and that heel is exposed, that is a huge, huge, huge risk for osteomyelitis. Peripheral vascular disease is also a big risk factor because the legs are open and they're constantly weeping can actually, obviously go into cellulitis, but then that cellulitis can travel to the bone. Can be acute or chronic. You're going to see fever, you're going to see redness, heat, pain, swelling. You're going to see, with that fever, you're going to see the chills. It's going to be long-term antibiotic therapy, and I'm talking like IV therapy, antibiotics for 6 to 8 weeks, maybe 2, maybe 3. So it's going to be hit really hard with the antibiotics, and orals will not cover it. They might actually go in and drain it, and the most common treatment for it once it's gone so far is amputations, whether it's just the toe, whether it's the top of the foot, so all of the toes, but once it's past that, they're going to go with a below-the-knee amputation. So if it's like a diabetic with a foot ulcer, the ulcer is very, very long-term. They get osteomyelitis starting in their big toe. They might have their big toe removed. So it just kind of really depends on where things are. But yeah, I've seen quite a few people, especially diabetics, with amputations. And when you actually start looking at your patient as a whole, most of the amputations you will see will be diabetics that started as a foot ulcer or something like of that nature. All right, moving on. Osteoporosis. Bone mass is low. The bone structure is actually deteriorating. This picture here with the one that says bone with osteoporosis, that is no joke. It looks like a sponge or Swiss cheese. It's usually it's very strong, very interconnected, and with osteoporosis, it's very open. It's kind of like a, oh gosh, what are those called? Coral, where it's just very, very fragile. Our little old elderly people with the osteoporosis, they're very, very, very prone to fractures because of the osteoporosis, because their bones are brittle. In the notes it says we don't always know what came first, the fall or the break. I have literally been helping a lady. She was standing up. It was a stand-by assist. She didn't even need help. She went to pivot and turned wrong, and because of her osteoporosis, she actually fractured her femur and then dropped to the ground right there. So a lot of times usually you think that somebody falls and breaks their hip, but because of osteoporosis, they might actually break their hip and fall. Compression fractures is just like compression on a bone. Happens quite often in the vertebrae, and it's just from sitting, or I had another lady who was actually standing up in an easy stand, and she really didn't do anything out of the ordinary. She just basically stood up, and when she moved, she received a compression fracture because she had osteoporosis. Signs and symptoms, you might see the hunchback, the doe-wagger's hump. Their height is actually going to decrease. So you hear like little old ladies talking about, well, I used to be 5'6", but now I'm 5'4". They're going to complain of back pain. A lot of times this is because of the compression fractures in their vertebrae. And then fractures. Sometimes people don't even know they have osteoporosis till they obtain a fracture, and they go to look at it a little bit more and find out that their bones are very brittle. What do we do to treat it? Try and reduce their risk factors. Big risk factors are little old ladies who have gone through menopause that are taking omeprazole, that do not drink milk and don't ever get out in the sun. So we want to make sure, and they don't ever do any weight-bearing exercises. So we want to try and reduce those risk factors. Medication, calcium supplements, vitamin D supplements, there's Fosamax, there's Actonel, to try and help build up that bone. Try and get them to drink milk. Try and get them out in the sun. Try and get them to start doing some weight-bearing exercises, and that way kind of keep those bones growing and building, and trying to keep them from falling is the big one. Biggest diagnostic tool there is the DEXA scan, and they can just tell how dense the bones are. All right, Paget's disease. Bone is just they're losing bone. Generally, they don't have a whole lot of symptoms, but it will be found on like the DEXA scan or an X-ray. So the biggest thing that we can do is provide pain relief, and give them a good quality of life. You can see this X-ray, and that's really what it looks like. That's kind of scary. Strains and sprains. Know the difference of these. So a strain is just like stretching or tearing of the muscle or the tendon. Generally, this is caused when somebody's overusing it. Like I don't exercise, but one day I wake up and decide I want to go to the gym, and I run 2 miles on the treadmill, and then I do some on the row machine, and then I want to lift weights. So I might actually strain my muscles by doing too much. Obviously, we're just going to treat the symptoms, so the RICE is a good acronym to use. It's rest, ice, compression, and elevation. A sprain, however, is like stretching or tearing of a ligament. You might see this more when somebody falls, sports injuries, motor vehicle accidents, something where there's actually trauma. They're going to have edema to it. It's going to be swollen. It's going to be painful, and they're not going to be able to move their joint very well. So again, we're going to treat it with RICE, rest, ice, compression, elevation, until it heals. And just remember that strain and sprain are soft tissue injuries. Gout. We kind of talked about this when we were talking about uric acid levels. It's a connective tissue disorder where uric acid is building up in the blood, and then these crystals, once they're circulating, they kind of just build up. And big common place is the big toe. So these crystals just kind of build up in the joint, cause swelling and warmth, pain. So it's primary generally. It's an inherited issue, and they can't digest or metabolize the purines. Like I said, it's in like cheeses and smoked salami and beer, and all those older guy favorite foods. And obviously secondary is related to another problem. Could be chronic renal failure, leukemia, diabetic ketoacidosis. A lot of times diuretics can actually cause gout. When they're taking it for a CHF, they take the diuretic, and that can actually cause gout. Alcohol consumption, especially beer, will cause more signs and symptoms, or more cause gout. Acute, obviously, it's going to, and this is exactly what it looks like. These two pictures here. It's going to be swollen. It's going to be red. The top one is the acute. Swollen, red, hot, painful, inflamed joints. And I'm not exactly sure what the science behind the big toe and why that's the one affected, but that generally is the one that's affected. Chronic gout is the hands picture here. It just gets to be the uric acid crystal. It's the urate deposits that actually get under the skin and build up. Can also cause kidney stones as well. So just kind of know the difference. Acute is more, looks almost like an infection, where chronic is just these build up in the joints of the urate deposits. Diagnostics, we're going to do a blood uric acid and then we're going to aspirate the fluid that's in the joint. I've actually seen this done once in my entire career, but it was really cool because when they pulled it out of the joint, you could actually see the crystals in the syringe. It was pretty interesting. All right. So what do? We are going to give colchicine. We're going to give NSAIDs like ibuprofen to decrease the inflammation. You've seen people on allopurinol. This is more so that the body isn't producing as much uric acid in like terms of like chronic gout. So they don't have all that the uric acid floating around and building up in the joints, so their hands don't look so deformed. Benamid, I've only heard of. I don't think I've ever given it. But it helps the kidneys excrete that uric acid, so it's not building up in the body, going to the big toe, or going and building up in the hands. We're going to teach our patients to really avoid those high purine foods, aspirin and diuretics. Can actually, like I said, some certain diuretics can actually cause gout in people, and if they've already had gout, the aspirin and diuretics can trigger an attack. And we're going to increase their fluids because the more fluids they have, the more diluted their blood will be and the less chance of those uric acid crystals building up in their joints. Oh, here it says avoid aspirin. It interferes with uric acid excretion. So just keep that in the back of your head. Going into systemic lupus erythematosus. It's an autoimmune disorder. Remissions, exacerbations, but like many autoimmune. Autoimmune basically means that the body's attacking itself, and it affects the connective tissues. There is a genetic link to lupus, and generally lupus is a systemic effect. It affects the whole body. There is a type, it's called discoid lupus erythematosus. This just affects the skin, more lesions type thing. So the systemic lupus, this young lady here has the characteristic butterfly rash over the nose, and then kind of the where the wings would be are on the cheekbones. They're going to be sensitive to light. Anytime they're out in the sun, it can actually increase their symptoms tenfold. They're going to have fever. They're going to be lethargic or fatigued. They might have weight loss. They're going to have skin lesions, especially like this butterfly rash. That might actually open up. And they're going to have hair loss. So what are we going to treat it with? Obviously NSAIDs, Tylenol for the pain, corticosteroids like prednisone. Because it is an autoimmune disorder, we want to make sure that we are suppressing that immune system so that it is not attacking itself. Antimalarials will be used, like methotrexate, chloroquine, topical cortisone cream. So just basically kind of helping out so that their symptoms are not as bad. A lot of it's decreasing the immune system so that it's not attacking itself, and then treating the symptoms. Education, we want to make sure that we're teaching them how to take care of their skin because of the skin lesions that do happen. Prolonged exposure to sunlight is a huge factor to decreasing the exacerbations of lupus. I had a guy once who had gone out fishing with his son and forgot his hat, and that was enough to throw him in a huge exacerbation. Exercise, as much as it sounds like it would be contraindicated because of it being a connective tissue order, exercise will help. Making sure that they are immunized, because especially if they're taking meds to decrease their immune system, they're going to be at a higher risk for infections like influenza and whatever else might be running around. Stress is a huge cause for an exacerbation. And then give them resources for the support groups in the community. Lupus can be a terrible illness, so if they have somebody else to talk to, that would be wonderful. Muscular dystrophy, basically their skeletal muscles are atrophying. Muscle tissue is lost, and their muscles progressively get weak. There isn't really any type of actual cure, so we're just going to supportive care, we're going to treat the symptoms, and try and prevent any complications. So if their skeletal muscles are atrophying and they're not getting up and walking like they normally would, we're going to watch for like pressure ulcers. So we just need to make sure we're preventing all of those complications that might occur. Yeah, it's just a muscle wasting disease. It's a terrible disease to watch. All right, osteoarthritis, also called degenerative joint disease, DJD. You've probably seen it. It's very common. It's very, very common. With osteoarthritis, though, make sure you know that it can happen on the right side of the body or it can happen on the left side of the body. It is not a symmetrical disease. It is not a symmetrical disease. It just, maybe the patient favors their left, so their right is working really, really hard, maybe their knee. So what it is, let me just double check my notes here. Okay, we'll go to the next slide. What it is, so you have a joint with the cartilage. Because of the wear and tear and the work that this joint is doing, eventually that cartilage is going to wear out. So the bones are going to wear on each other, and eventually those bones are going to wear each other away. Generally, it happens most on the hips, the knees, the hands, and the vertebrae. Hips and knees, the osteoarthritis in the hips and the knees is why we have joint replacements. So, causes are really kind of unknown, but basically it's a wear and tear disease. Risk factors, aging, obesity. If somebody is obese, those joints are working harder because they're trying to get the body around. Here's that wear and tear thing. Signs and symptoms. Joint pain is going to get worse with activity. They're going to be stiffer with activity. They're also going to have Heberden's and Bouchard's nodes. So it's on there. You can see in this picture here. They're right on the joints of the fingers, and they do show through their skin. You will see them. All right, diagnostic tests for osteoarthritis: CT, MRI, biggest, and X-rays. There is no cure. Medication, NSAIDs, rest and exercise, heat and cold, weight control because it worsens when people are overweight. And then complementary therapies is a big treatment modality for this. Guided imagery or music therapy, acupressure, acupuncture, anything that is non-pharmacological. Like I said, osteoarthritis is a cause for the total joints, the total knees, the total hips, the replacement. Rheumatoid arthritis. Fun, wonderful disease. It's chronic, it's progressive, it's a systemic inflammatory disease. It's autoimmune, so it destroys these synovial joints and other connective tissues. It also can affect eyes, lungs, heart, major organs. So the body in the synovial joint, there's inflammatory cells because the body is attacking itself, and it causes synovitis. The synovium thickens, fluid accumulates in that joint, causes swelling, and then the new synovial fluid that has all these inflammatory cells is called pannus. So then this pannus actually erodes the joint cartilage, and then eventually this pannus will be converted into like a bony tissue, causing deformities and getting rid of all that other nice connective tissue that we like in there. Like I said, it is an autoimmune disorder, so we're going to treat it the same idea as lupus. We're going to suppress that immune system. Rheumatoid arthritis, unlike osteoarthritis, rheumatoid arthritis is bilateral, symmetrical. So if you have it in your left thumb, you're going to have it in your right thumb. If you have it in your right foot, you're going to have it in your left foot. So it's on both sides of the body, whereas osteoarthritis osteoarthritis can be just one-sided. Signs and symptoms, remissions, exacerbations. Some days are going to be better than others. Early symptoms of it, like I said, it's bilateral, symmetrical, both sides of the body, both joints are going to be inflamed. Their joints are going to be red, warm, swollen, stiff, and painful. And like with osteoarthritis, when these people are in osteoarthritis, people have more pain after activity. But with rheumatoid arthritis, there's going to be more pain after they're resting, when they're getting up in the morning, and then once they get moving and do some activities, their pain and stiffness is going to go away. Rheumatoid arthritis also includes the organs, especially lungs, eyes, heart, can really be affected. Late symptoms of RA is joint deformity, obviously, because there's, that pannus is in there and it's becoming bony material and causing the deformities. These guys can also have secondary osteoporosis. All right. So to diagnose rheumatoid, that RF, the rheumatoid factor, is going to be positive. They're going to be checking the red blood cells, obviously. The C4 complement is going to be decreased. The ESR is going to be elevated, because remember that tells any inflammation in the body. The anti-nuclear antibody is going to be increased because it's looking for an autoimmune disease. And the C-reactive protein, the CRP, is going to be elevated because it also tells us about inflammation somewhere in the body. And remember, the CRP is going to be a lot quicker to respond and show a positive result when compared to an ESR. Medical treatment, most common is methotrexate and prednisone. Obviously, pain management is another big thing. But we're just going to suppress that immune system and try and get that immune system to quit attacking itself. Obviously, heat and cold, we're going to try anything non-pharmaceutical, like we talked about earlier, the guided imagery, the, what all is there? Mindfulness, the acupressure, acupuncture. And these guys really need to balance their rest and their activity. Don't go 100 miles a minute and never stop, because your pain will be much worse. Then these guys are also going to get joint replacements because their joints are deformed and covered in bony material. For patient education for RA, we need to make sure that we are discussing the entire disease process and what to expect. The medication management, there are so many meds out there for RA, and they're all different, and there's always a million side effects for them. Obviously, rest and exercise, how to balance, and then we want to give them some community resources, support groups, counselors, anything like that, because it is a debilitating disease. All right. Total hip replacement, THA, total hip arthroplasty. the top of the femur, like the ball, is basically cut off, and there's a new component placed in the acetabulum. So there's two components to it. There is a piece that is actually, they drill out the top of the femur and pound that appliance down into there and cement it in place. There's a lot of preoperative care that goes into a total joint. I used to work ortho with Dr. Lawrence in Viroqua, who is one of the most well-known ortho surgeons, I want to say, in the nation. But they actually have to go to classes, and they have to show that show them that they can do their exercises. It's a really big deal for them to be really, really prepped before they go into surgery. It's not something that they take lightly. All right. Post-op care is basically put to prevent complications and to get these people up and moving. So we're going to make sure that they're not having any internal bleeding. H&Hs are done, I think, 3 hours after surgery, and then again at the morning after, and then follow-up care after their discharge. I know we talked about this as one of the scenarios, but that hip joint can actually hold a hidden amount of blood. So these people are going to have hemovac drains generally in place for a little bit, just to get rid of all that blood so it's not clotting up in there. Neurovascular, just because they're doing a lot of, I call it the back tool shed when I saw the surgery. There's saws, there's hammers, there's, you name it. So there's a lot of risk for neurovascular compromise. Pain, although I will tell you that the most of the people that I worked with said that their pain after hip surgery was 100 times better than the pain they had when they walked in the door before surgery. Risk for dislocating that hip, we'll get into that in the next slide. Skin breakdown, because they're not as mobile as they used to be. Infection, there's a lot that goes into this. They will be given prophylactic antibiotics on their way to surgery, in surgery, and then after surgery. We need to make sure that they're not getting pneumonia, and then we need to make sure they're not getting any infection in that incision. They can actually get an infection in that appliance years down the road. They could get an infection somewhere else in the body, and it just travels. And bugs are really attracted to the metal in the appliance. So even years down the road, people can end up with an infection that basically hangs out and vegetates on that appliance. I actually have somebody I know right now who had their hip done, I don't know, 4 years ago, maybe-ish, and ended up with an infection. And what they do is they actually take that appliance out and put some spacers in there, but they're really functioning without a hip joint at this time because they had to put some antibiotics in there, get all the infection out of there before they can put a new appliance in there. So it gets to be a pretty big thing. I think it's 6 weeks that they're without a hip joint. And yeah, it's really kind of weird to see. And even the person I know will joke about that. They don't get it because they can move their leg, but it's more like the muscle movement. But just know there's a huge, huge risk for infection. And then bleeding. We want to make sure that we're monitoring the output in the drain. We're monitoring that incision for any drainage. And we're watching because generally the hip replacements are a lot less blood loss during surgery, but can actually be quite a bit and require blood transfusions. Continuing on, ambulation. I've not seen anybody use crutches right after surgery, but they're going to be using a walker, wheelchair for long distance. But Physical therapy and occupational therapy are the bosses when it comes to these guys in the hospital. They're going to tell us if they're safe. They're going to tell us when they get to go home. So we really need to listen to our PTs and OTs. What was I going to say? So these guys, when they go in and have their hip surgery, they're going to be standing at the edge of the bed marching the night of hip surgery. And then the very next morning, PT, OT is going to come in, especially PT, and they're going to get them up walking. And then by the afternoon after surgery, these guys are walking down the hall and doing stairs. So it's not have surgery and then lay around and wait. It's get up and move. So really getting them up walking ASAP is going to be good for them. Obviously, they're going to have thromboembolic complications, so we want to prevent any problems with blood clots. They're going to have SCDs, the sequential compression devices. Generally, these guys just have the feet pumps. We're going to teach them leg exercises. They're going to be on Lovenox in the hospital, and they're going to go home on Lovenox as well. Because they're given Lovenox until their INR, because they'll be eventually on, or they're on Coumadin as well, but until their INR is 2.0 and higher, they're going to be taking this Lovenox, and they're going to go home with it. Older practice, these guys were on Coumadin, but I did talk to the ortho guy today, and he's actually working on getting people switched over to the newer blood thinners like the Eliquis. Honestly, I'm a little nervous about all the Eliquis and all of that. I kind of like to know what my levels are, and I need to know that I have an antidote. If I start bleeding, I need some vitamin K. That's with the Coumadin. But with the Eliquis and those newer generations, there's not a lab test to monitor how thin the blood is, and there's no antidote right now. Just all they do is stop taking it. So, and then self-care. Generally, we're going to be teaching family how to help take care of these guys. A raised toilet seat. They're going to have PT, OT as an outpatient. But the biggest thing that we need to know with our hip people is that they cannot cross their legs past midline. So they can't cross their ankles, they can't cross their knees, and then they cannot bend their hip more than 90 degrees. So they can sit up straight in a chair, but they cannot go past that. So if they're sitting in a chair and they drop something, they cannot bend over and pick it up off the floor. Because if they're crossing across midline or bending down past 90 degrees, they could actually pop that new hip joint right out just because there's nothing holding it in place until it heals a little bit. For patients that aren't able to keep their legs from crossing, maybe it's a demented lady who fell and had to have a hip repair, there is what's called an abductor pillow. What's it called in the notes here? A bolster pillow. But they can put that in between their legs. It's kind of a triangle that goes between their legs, and so when they're rolling or when they're sitting or laying in bed, their legs won't cross midline and they won't bend at 90 degrees. Total knee replacement, there's 3 components to it. There's the femoral component where it's actually drilled out and pounded into the femur, and then there is the tibial component where it's the same thing into the tibia, and then there's the patellar component, the kneecap. Dislocating a knee is not anywhere near as a concern as with the hip, and care is kind of the same as the hip with the Coumadin, the Lovenox, the getting up and walking, getting them as active as possible, marching at the bedside the night of, PT, OT, really hitting it hard, walking in the morning in the room, and then in the afternoon walking out in the hallway, doing steps, and then discharge. What is different is that these guys are using what's called a continuous passive motion machine, a CPM. So it just measures how much bend they have and helps them bend and straighten their knee. So they can be laying in bed. I don't remember what the exact time frame is how often they need to be on the CPM, or if they're, kind of phasing it out. But they can lay there and their leg will just actually move and bend as they're laying there with the machine. And then you can stretch it out so they're straightening their leg a little bit more, or they're bending it a little bit more. So maybe they're only bending a little bit, after surgery, but the next morning you can, so they're straightening more and they're bending more. You can increase the bend. Sometimes people just have a partial knee replacement. All right, last topic. Amputation can be surgical and can be traumatic. We kind of talked about this. Most common amputation is from like osteomyelitis or diabetes. A lot of times you might see it with ischemia from a peripheral vascular disease, where there's just no blood flow in their foot. I have seen amputations because of frostbite, infections, and then obviously if there's a tumor in the bone, they're just going to get rid of it. They're not even going to mess around. They're just going to get rid of it. Traumatic amputations, obviously car accidents. What comes to mind is like a chainsaw accident. So if you are ever out in the field and somebody has a traumatic amputation, wrap that body part in a cool, slightly moist cloth. Keep it wet and moist. Put it in a sealed plastic bag, and put that bag in cold water. And then transfer it to the hospital as soon as possible. Above the knee amputations are generally traumatic. Below the knee is generally more like infection and wounds and osteomyelitis and decreased circulation is generally below the knee. All right, last slide. Amputation. Still, post-operative care. We want to make sure these guys are not hemorrhaging. Obviously, with any surgery, trauma, it's a concern. Infection is a big concern. Obviously, with the surgical, that's a major surgery. Pain control. This is where it gets a little tricky. So if I have a below the knee amputation on my left side, I can actually feel pain in my left foot. It is no longer there, but I can feel pain as though my foot's still there. It's called phantom pain. It's a real issue, and I have seen it many, 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 many times. We need to treat it as if they have a left foot and it's in pain. It's very hard to treat. One of the most common meds is the gabapentin because it's a nerve pain. It's also an anti-epileptic. Another thing that I learned is that, say, if they're having pain in their foot, put a mirror so that they can see. So put a mirror in between their legs and face the mirror towards their unaffected side. So that way when they're looking at it, they can look at it down and see the unaffected side, and it'll also look like their affected side still has the foot. And sometimes that helps. It's really kind of a cool idea. Mobility, ambulation, preventing contractures. We want to make sure that they're doing range of motion, especially those guys that have the below the knee amputation. The contracture in that knee, the risk is very, very high. So we want to make sure they're doing range of motion, bending, straightening, so that they're not getting that contracture. Because if they do get a contracture, they'll never be able to get a prosthesis and start walking. So right after amputation, we want to make sure that stump is elevated for 24 to 48 hours, just to make sure that they're not getting any swelling, because if they get swelling in that stump, it can actually bust open the incision, and then there's going to be a lot more problems. They do put what's called a rigid dressing on these guys, so it just kind of helps mold that stump because it is kind of a flabby. If they don't do the molding, it's just kind of flabby. I don't know how else to explain it. When they mold it so that they can eventually get into a prosthetic. And they just do it with everybody, whether or not they're planning on getting a prosthetic, just in case they ever do change their mind where they want a prosthetic leg. Because that incision is in such kind of a weird spot, it is very common for people to bump that stump. Whether it's on their bed, whether it's, they're getting up and moving and they bump it on their wheelchair. But we need to really, really, really try and help them from preventing any time the hitting or bumping that stump, because it could actually dehisce that wound. And then once it gets open, it's a huge risk for infection, which could eventually lead to osteomyelitis. So we need to make sure that the wound edges from that surgical incision are becoming well approximated. When you're make sure that, especially a diabetic, we are not bumping that stump, because with diabetes, obviously there's poor wound healing, so they're even a higher risk for, if they have their amputation and they're running around in their wheelchair and they bump their stump, they're at a higher risk for that incision opening up and never healing, and then they're going to get a huge infection. Lifestyle adaptation, it's a major life change. So we just need to make sure that they're, not becoming depressed because of their body issues and the way they view their body. And it can take a very active person and put them, in a very sedentary lifestyle, because they can't get up and move, and it's just kind of a vicious cycle. All right, I think that is it, and I'm going to go to bed for a couple hours and get up and go to clinical. But if you guys have any questions, I will post this so it opens up on Friday at, I think I opened the other one at 5. But if you guys have any questions, either class, just get a hold of me. I'm sorry, I'm tired and I'm saying a lot. But have a good night, guys. All right, talk to you soon.